So, Fred, these patients get the typical toxicities, cytokine release syndrome and neurologic toxicities. Would you like to discuss that?
Yeah, so with CAR T-cell therapy, of course, these patients are getting conditioning chemotherapy, so they may have transient hematologic toxicities. But there's really two main categories of toxicities with CAR T-cell therapy, and that's the cytokine release syndrome, or CRS, and then neurologic toxicities. And cytokine release syndrome is really characterized by elevation of high cytokines, and patients may develop fevers, hypoxia, hypotension. In severe cases, patients may need pressors to maintain their blood pressure or mechanical ventilation. The neurologic toxicities are often sort of characterized by expressive aphasia, but it can lead to both confusion. Patients can develop seizures. Some patients have more serious neurologic events like cerebral edema, which are relatively rare and seem to be related to the type of construct used. In general, the management of these toxicities for cytokine release syndrome is to use the anti-IL-6 receptor antibody tocilizumab, which is approved in the US for the treatment of cytokine release syndrome. And we also use corticosteroids for patients. And in general, the use of these agents has moved into earlier lines. For the neurologic events, tocilizumab doesn't seem to do a lot for the help of those neurologic toxicities, although if they're in conjunction with CRS, tocilizumab can be used, but corticosteroids is the mainstay of treatment for the neurologic toxicities.
Now, we've seen when the original trials with the Ileana data were published, I think there was a general reluctance to intervene for treatment of CRS or neurologic toxicity because of fear of actually blunting the anti-tumor effect. And I think the original trials had really waited a long time until, in fact, patients were in the ICU or on pressors. And there's been a kind of an evolution of that. I mean, I think we saw that in the real world data a little bit, right? The incidence of severe CRS and neurologic toxicity, well, at least the CRS anyway, seems to be less at grade 3, 4 than what was seen. Do you see that this evolution is going to be able to make this easier to be done in the clinic?
So I do see across multiple clinical trials and in the standard of care setting that people are using tocilizumab and corticosteroids at earlier grades of toxicity, CRS and neurologic events. And it does appear that the earlier use leads to decreased incidence of the severe events and does not appear to be impacting at least response rates. We may need more time to look at durable responses, but I think that it's giving us more confidence in the ability to use these therapies safely.
We early on had patients who were very savvy and who read about these therapies, patients who would actually ask us, please don't give me steroids when they were getting their CAR T-cell because of fear of potentially losing responses. However, as more time has emerged, I think I agree with Fred that we're seeing encouraging results that may not have an impact.
Yeah, I think that's actually a dangerous position that we have to be careful about, that we don't convey that to the patient in the clinic, because I too have had that situation where people are refusing or won't allow us to give them steroids for fear that that's going to blunt their anti-tumor effect. In reality, if we need to do that, then I think they need to understand that if they're sick enough to need that, then we need to go forward. So it's, I think, an important message to give to your patients that if we do have to intervene, it doesn't mean that the CAR T cells are not gonna work.
And we also can say that if you actually treat a patient with grade 1 cytokine release syndrome or grade 2 neurotoxicity early onwards, we may prevent of them going to grade 3, grade 4, where our algorithms actually then suggest to use not just milligrams of steroids, but gram portions of steroids, which then obviously may have a more detrimental effect in that situation.
I think we may see some very really small subset analyses though that show that sort of cumulative doses of steroids and things like that may impact overall outcomes, and I think we have to be careful about those analyses though, and they really have to be powered for multifactorial analysis, because we do know that patients who have high tumor volume are also the ones that are more likely to have high grade toxicity, which therefore would be the ones that were more likely to need more of these agents, but those are also the patients who are less likely to have durable responses. So whether whether it's the treatment of the toxicity or their inherent disease that's leading to the detriment and outcome, I think that really remains to be seen.
And that seems to be really true in ALL, where disease burden may matter. Do you guys have an experience with that?
Yeah, I mean, I think that the data from published trials suggest that the bone marrow blast burden correlates with a higher degree of CAR T cell-related toxicity.
I think in the Sloan Kettering data as well, that patients who were less than 5% blast did substantially better in terms of long-term outcomes than people with greater disease burden.
And I mean, we're talking about pediatrics right now, but the ROCKET study, which was that construct taken into an industry-sponsored study in adults, they had two separate cohorts. They had the MRD positive cohort where they didn't have morphologically positive disease, and then everyone who had morphologically positive disease. And their early data certainly looked like the degree of disease burden predicted for a response.